various clinical uses in the treatment of cardiovascular diseases. Okay, so let's look at the learning outcome. Before you start with this lecture, I hope that you have gone through the pathophysiological changes of acute and chronic heart failure in pathology, and this is also the time to recap your cardiovascular physiology lah. Okay, so in this lecture today, you need to categorize the drugs used in the treatment of heart failure according to their mechanism of action. And then you need to give examples of the drugs in each category. So there are diuretics, vasodilators, cardiac glycoside, sympathomimetic amines, and other miscellaneous agents. For each of the drugs, you need to identify the relevant pharmacokinetic properties, the mechanism of action, the adverse effects, okay? And I would like you to be able to discuss the role of newer drugs in improving the prognosis of heart failure. So this lecture is based on the clinical guideline produced by KKM lah. So I think the guideline, I will upload the guideline in goals, okay? So we have a look after this. What are the guidelines of treating heart failure in Malaysia? So just a recap of your physiology. In a normal condition, the heart will be able to meet the body's demand through sufficient cardiac output. So you have a cardiac output, and it's a function of the stroke volume and the heart rate. Okay, so every stroke volume, which is the volume of blood which is being pumped out from the heart in a minute, depends on three factors, which are the preload, the afterload, and the contractility. So you know about this. So anything that influence the preload, the afterload, and contractility will influence the stroke volume, hence will change the cardiac output, whether there's increase in cardiac output or reduce in cardiac output. So for example, in the case of hypertension, okay, there is increase in the resistance that the ventricles need to overcome. So there's increase in afterload. So when there is increase in afterload, basically your stroke volume will be reduced lah, and the cardiac output will be reduced. Okay, so so there are many factors that influence the preload, afterload, and contractility. I just hope that you can go back and have a look at what are the factors. Okay, so heart failure is a complex clinical syndrome. It's a syndrome, it's a condition, it's not a diagnosis. So when you present in your clinical years, you cannot say that the diagnosis is heart failure. Okay, it must be heart failure secondary to something. Heart failure secondary to uncontrolled hypertension. Heart failure secondary to myocardial infarct. Because it is a condition, it's not a clinical diagnosis. So it's always associated with underlying pathological condition. And if there is a small decline of cardiac output, the body could tolerate lah, because we have this compensatory mechanism inside the body. Okay, everyone has this compensatory mechanism. So if there is a small decline of output, actually the body can compensate and try to keep up with the cardiac output to meet with the body demand. But over time, if the heart could not keep up with the compensatory mechanism, the heart, it's like you are the kereta lah kan. Kalau you ada kereta, you punya enjin rosak, you try to change the oil, for example, hantar pergi service, but over time the car just fail over you kan. Engine memang dah is not working anymore, then it will result in this situation, it will result in worsening the cardiac output, and then you call it as decompensated heart failure or congestive heart failure. So if you look here, a normal heart, this is the shape and size of a normal heart, but then in the heart failure, the heart tends to enlarge a little bit, okay, because it's not working, the pump is not working, but the heart is actually pumping. So there is a hypertrophy. Tak ada pointer. I think battery dah habis kot. Okay, so there is hyperplasia of the heart muscle causing enlargement of the heart. So whenever the heart is not pumping enough, actually the blood volume actually will be backlog to the extracellular spaces. So that's why you have fluid surrounding the lungs and then fluid at the periphery. So patient tends to have edema, especially at the both legs lah. So peripheral edema. Okay. So there are two different conditions of heart failure. This is a clinical description of heart failure. We refer it as ejection fraction. So ejection fraction refers to a diastolic function. So usually in heart failure, the systolic function, okay, the contractility is normal, but the diastolic means the relaxation of the heart could be impaired. So if a normal healthy heart, the ejection fraction is 55 to 70%. So the the ventricle relaxes and then it pumps into the systolic function and then pump out the blood from the heart. Either it goes to the lung or it goes to the systemic circulation. In a condition called normal or preserved ejection fraction is heart failure with preserved ejection fraction. The ejection fraction is still 50%, okay, more than 50%. But the heart is actually failing, okay? The heart is not relaxing enough. You see here, it's thickened, the wall of the heart is thickened. And it's hard for the heart to relax and fill with blood. So blood cannot fill in properly inside the ventricles because it is already thickened and stiff. Okay, but the ejection fraction remains above 50%. Another condition is called heart failure with reduced ejection fraction. So it is HFrEF. The ejection fraction is less than normal, which is 40%. So you can see the walls of the myocardium is actually quite thin and the heart pump is quite weak. So most of the blood stays inside the ventricle instead of being pumped out outside the heart. Okay, so as I mentioned earlier, heart failure almost always has an underlying cardiac pathology, and most of it is related to the coronary artery or the heart disease itself. So coronary artery disease constitutes about 68% of heart failure. Sometimes can be caused by heart valve disease or cardiomyopathy or uncontrolled hypertension, congenital heart disease, core pulmonary pericarditis, and acute rheumatic fever. So these are the list on the right side is caused by everything related to the heart and also the blood vessels. But there can be other causes of heart failure. If you look at the left side, either there's increase in the demand, for example, like tachycardia, induced cardiomyopathy, or high output in patient with severe anemia. Okay, or even toxicity, alcohol, chemotherapy can result in heart failure. So, when there is a reduce in the cardiac output, as mentioned, there will be a compensatory mechanism. So what happens is that there will be reduce in the activity of the baroreceptors. And when there is reduced activity in the baroreceptors, it will activate the sympathetic nervous system. Okay, this is a fight and flight reaction. So you activate the sympathetic nervous system and it will result in peripheral vasoconstriction. Okay, tachycardia, increased contractility. So this is a function of your noradrenaline and adrenaline can. So it will increase the vasoconstriction to maintain the blood pressure. It will stimulate the heart to cause tachycardia and increase in the contractility. At the same time, it will also stimulate the renin-angiotensin-aldosterone system. Okay, due to reduce in renal perfusion. So basically, when there's a reduce in cardiac output, reduce perfusion to the renal. Okay, because they want to conserve the blood to certain organs such as the brain. So there's a reduce in the renal perfusion. It will stimulate the renin-angiotensin-aldosterone system, and the angiotensin 2 receptors will cause vasoconstriction, and aldosterone will cause salt and water retention. At the same time, there's the vasomotor center also will stimulate vasopressin, which is an antidiuretic hormone. So as the name goes, it causes constriction of the blood vessel and it prevents diuresis. Okay, so there's a reduce in urine output. Everything, the compensatory mechanism is to conserve the blood volume or cardiac output of the heart. So what happened when there is a stimulation of the sympathetic system, stimulation of the renin-angiotensin-aldosterone system? Patient with heart failure will often have symptoms of fluid overload and systemic hypoperfusion. Okay, for example, here as you can see, patient with heart failure will have dilated pupils, and this is sympathetic response. dyspnea or difficulty in breathing or shortness of breath. Okay, this is because of pulmonary congestion. There's antidiuretic hormone. You are trying to conserve this sodium and water inside the body. Instead, the patient can have lung congestion. Okay, there's too much water inside the lung, and because of the water inside the lung, patient cannot lie flat. Okay, they cannot breathe. So there's autopnea. Okay, autopnea is difficulty in breathing unless they are sitting up. So the patient cannot lie down flat. Okay, there crackles and wheeze and also cough because they have fluid in the lung. Decrease in the blood pressure because of the activation of the sympathetic system tadi, causing vasoconstriction, and then tachycardia and contractility. Eventually, decrease in blood pressure is because of the reduce in cardiac output, which will stimulate the nervous system. So patient can have tachycardia and increase in the contractility. Patient have nausea and vomiting. Ascites again is caused by congestion of the water and also pitting edema. Okay. Similarly, the signs here are all signs of heart failure. Jugular vein is distended. Okay, patient may have infarct because of the decrease in cardiac output, fatigue and tachycardia, enlarged spleen and the liver, decreased urine output because the body is trying to conserve the blood volume. Okay, so these are the presentation of acute heart failure: very gasping, hypoperfusion, difficulty in breathing, and sometimes patient got chest pain. Okay, so in terms of clinical practice, you can describe the severity of the heart failure based on the New York Heart Association functional classification. So if a doctor or a consultant will ask you, you mentioned that the patient had heart failure, then the consultant will ask you, what class is it? Okay, so if you say like class 3, it means that the patient has marked limitation of physical activity. So it's understandable lah, based on the NYHA classification of heart disease. So this is more of clinical classification. Okay, so let's look at the management of heart failure. Okay, you know the pathophysiology of heart failure, you know the presentation of heart failure, and the management of heart failure consists of non-pharmacological therapy, non-drug therapy, you have drug therapy, you have surgery, and also device therapy. So in terms of non-pharmacological therapy, you are trying to change the lifestyle of the patient, okay? Reduce the high-risk lifestyle. You advise the patient to do more exercise, to avoid salt intake, control the fluid intake, okay? Because of the congestion of difficulty of the patient to regulate the blood volume. So you advise the patient to actually control. Patient with heart failure, if you notice, they measure, okay, dia punya water intake daily, they measure dia punya urine output daily. So dia punya water intake should not be more than the urine output. If it's more, then the patient tends to have congestion of the lung. Okay, you advise the patient to stop high-risk behavior, stop smoking, reduce alcohol, stop any illicit drug intake, if there is any lah. Okay, for pharmacotherapy, there are drugs that helps to reduce the symptoms of heart failure, and also drugs to actually improve the cardiac function. So in terms of improving the symptoms, you have diuretics, you have mineralocorticoid receptor antagonists, MRA, you have vasodilators. Okay, other drugs, the ACE inhibitors, ARB, beta blockers, digoxin, ivabradine are drugs that are used to improve the cardiac function. Okay, so in terms of correcting the function of the heart, the patient may undergo coronary artery bypass graft. Okay, let's say that the patient has myocardial infarct, and it can be corrected with surgery, then you can offer CABG. Okay, and this is for myocardial infarct lah. Kalau ada masalah lain, mungkin tak boleh with surgery, so you have to resolve with only pharmacological therapy. Okay, if the patient got arrhythmia, you can give a device therapy, which is known as cardiac defibrillator lah. So you put a pacemaker at the heart to control the heart rate. Okay, so these are surgical treatment, but we are going to concentrate on pharmaceutical therapy in this today's topic. Okay, so let's look at the drug use. Okay, the first one, which is to reduce the symptoms of acute heart failure, is the diuretics. Okay, so you have learned about diuretics before. Diuretics are used in acute heart failure to treat volume overload and reduce congestion. So you just imagine patient with heart failure, there's fluid filling up the lung. Okay, so you need to remove the fluid from the body, otherwise patient cannot breathe. So you have a few choices of diuretics that you can use. Namely, loop diuretics consists of furosemide and bumetanide. So you can give IV or oral. In acute cases, most of the time you give IV because you want a fast action. Patient dah gasping, you tak boleh suruh telan orally, memang tak menjadi, and will take some time for it to work. So you give IV furosemide. Okay. Other diuretics that you can use but may not be so potent as loop is thiazides. You have example of hydrochlorothiazides and metolazone. Can give orally, and also you have the potassium sparing diuretics or the mineralocorticoid receptor antagonist. Okay, it's the same thing. So the example of drug is spironolactone. So you give orally. Okay. So loop diuretics here, it acts at the ascending loop of Henle, thick ascending loop of Henle, and it actually will block the sodium potassium chloride cotransporter. So what happened is that it will increase the excretion of sodium, increase the excretion of potassium, and also chloride. Okay, you know thiazide acts at the distal convoluted tubule by blocking the sodium chloride transporter, increase the sodium chloride excretion. And for the spironolactone, which is a mineralocorticoid receptor antagonist or potassium sparing diuretic, it will antagonize aldosterone receptor at the collecting duct. Okay, so out of the three diuretics that's used, okay, loop, thiazides, and mineralocorticoid, only spironolactone or potassium sparing diuretics will cause hyperkalemia. Okay, whereas loop and thiazide will cause hypokalemia because it increases the potassium excretion as well. So what are the results of diuretic treatment? Okay, as you know, diuretics memang dia nak buang air lah. So there will be increase in the sodium and chloride loss, increase in the urination. Okay, so when there is increase in the water loss, it sort of like reduce the cardiac payload, reduce the congestion, and in long term it will reduce the afterload. Kan? So diuretics, as you know, is also used in the treatment of hypertension. Okay, because it can reduce the afterload. This is a long term lah. But the acute effect that we want is to increase the diuresis and natriuresis lah. So it will sort of reduce the cardiac payload and reduce in the cardiac congestion. So the adverse effect, there will be deficiency of the main electrolytes, mainly the hyponatremia equals hypokalemia and hypomagnesemia, except for if you use potassium sparing diuretics lah. So there won't be any hypokalemia. Okay, because of the hypokalemia, patients are susceptible to ventricular ectopic. This is arrhythmia secondary to hypokalemia. Okay, if the patient is taking loop diuretics, patient can have hyperuricemia, and it can also precipitate gout. Okay, increase in the serum cholesterol levels and impair in the glucose tolerance. So these are adverse effect of thiazide diuretics. Okay, so you know about your diuretics, just go back to your lecture on diuretics agent and then look at the adverse effect and mechanism of action of diuretics. Okay, so the second drug that is used to improve the symptom of heart failure is the vasodilators. Okay, vasodilators, as its name implies, it dilate the blood vessel to restore the oxygenation and organ perfusion. So there are, I mentioned before, in drugs used in angina, what is the vasodilator that we usually use? GTN. Okay, that is a type of vasodilator. So this is another type, the nitroglycerin, which is a vasodilator also. It is given intravenously. The mechanism is the same. Okay, it releases nitric oxide within the vascular smooth muscle. So there's another drug called sodium nitroprusside. This one, it does not need to be metabolized. It will release the nitric oxide spontaneously. Okay, but the main substrate is still nitric oxide. Okay, the active agent is still nitric oxide, which will vasodilate the blood vessels. And you know what will happen, like I mentioned before in my previous lecture. Okay, what will happen to the blood vessel caused by nitric oxide. And again, I show you the diagram that I've shared earlier. What will happen, will dilate the coronary arteries, will dilate the arteries and also the vein. Okay, again, this is the effect that we want. It relieves spasm and blood flow. It will reduce the afterload. It will reduce the preload. But with that action, it causes adverse effect. Okay, patient have tachycardia, patient have throbbing headache and flushing, and also orthostatic hypotension. So please go back to this diagram and look at the mechanism and adverse effect of vasodilators. It's still the same. Okay, so that are the two drugs that are used to reduce the acute symptoms of heart failure. This one are the list of drugs that modify agents. They are called modifying agents to reduce mortality. So what it is used is basically in those with chronic heart failure, meaning that they have passed the acute heart failure stage. They are not in a congestive state anymore. They are more stable, but the cardiac is not functioning well. Okay, the heart is not strong enough to function normally, so you need to support it with various drugs. So we are not using diuretics rigorously in the terms of chronic heart failure, but we still supplement them with diuretics, oral diuretics. Usually we give thiazides, not a loop diuretics. Okay, so in terms of disease modifying agents, we have a list of drugs that is given in stepwise manner. This is based on the guideline by KKM. So maksudnya you tak terus pergi ke cardiac digitalis. No, you start with ACE first, ARB, beta blocker, and there are reasons. Okay, the reasons being is that the first drug has lesser adverse effect, better improvement of the heart function with lesser adverse effect. So that is what we want actually. So the first drug is angiotensin converting enzyme inhibitors or ACE inhibitor. So the example of drug is captopril, enalapril. So this is all the pril lah, lisonipril, perindopril, ramipril. Okay, the second drug is angiotensin receptor blocker, ARB. So this is the satan group. Okay, candesatan, losartan, valsartan. Then you have the beta blocker group. This is a new one that I introduced. Okay, angiotensin receptor blocker, neprilysin inhibitor, ARB and I. So it consists of two different drugs that are given in one tablet and act synergistically. Okay, so it's sacubitril and valsartan. Sacubitril is the neprilysin inhibitor, valsartan is your ARB. So it's a combination of drug. Okay, the fifth drug group is cardiac digitalis. There's only one example, which is digoxin. And then you have the IF channel inhibitor that we have learned before, which is ivabradine. So there's only one example of drug for that group. Okay. Okay, so let's look at ACE inhibitors. So you have known about this, okay? You learn about this in your antihypertensive agent. So what happened when there's a reduce in the cardiac output, the liver will release the angiotensinogen, and the kidney will convert, the kidney will release renin, which convert the angiotensinogen to angiotensin 1. Okay, and then you have angiotensin converting enzyme that convert angiotensin 1 to angiotensin 2, and the angiotensin 2 will act the angiotensin receptors lah. So you have angiotensin receptors 1 and angiotensin receptors 2. Okay, so ACE inhibitor, as the name implies, angiotensin converting enzyme inhibitor, it will inhibit ACE enzyme, which changes angiotensin 1 to angiotensin 2. So angiotensin 2 is not being produced here when you give the drug. Okay, so when the angiotensin 2 is not being produced, instead of having vasoconstriction, patient will have vasodilatation. Okay, instead of sodium and water retention, there will lesser retention of sodium and water, and will decrease the vascular resistance, decrease the afterload because of the vasodilation, decrease in the preload because there's no retention of sodium and water, and in long term, you can increase in the cardiac output. Okay, the adverse effect of that is that ACE inhibitor will also reduce inactivation of bradykinin. So bradykinin is a potent vasodilator. It will convert into an inactive metabolite by ACE. But now you are inhibiting the angiotensin converting enzyme, so bradykinin remains active, and this will cause a very annoying adverse effect, which is cough. Okay, so patient taking ACE inhibitor is known to have this adverse effect, which is cough. Okay, so what are the adverse effect of ACE inhibitor? It will cause postural hypertension because there's a vasodilatation. Ingat, ACE inhibitor is used as an antihypertensive, so patient can have postural hypertension. Persistent dry cough caused by increase in the bradykinin. Okay, blood is not supplying the kidney, and it can cause renal insufficiency because of reduction in renal perfusion, basically because of the vasodilatation. And also hyperkalemia because there's no action of the aldosterone. Okay, so renin, angiotensin, aldosterone, so angiotensin 2 is not being activated, so aldosterone is not being activated, and it can cause hyperkalemia. Okay, so for those who cannot tolerate ACE and they cannot tolerate, not because of the vasodilatation, not because of the hyperkalemia, but they cannot tolerate because of the cough. So that is the main complaint. You can change ACE to ARB. Okay, so the mechanism is still the same. The adverse effect is still the same, except that patient who take ARB would not have cough because the ARB is not changing the angiotensin converting enzyme. Okay, so bradykinin can be inactivated. It will change to an inactive metabolite, and it won't causes cough in the patient. So clinical effect and adverse effect of ARB is similar. Okay, the mechanism is a bit different. ARB will act at the receptor itself. Okay, whereas ACE will act at the enzyme. We inhibit the enzyme. So ARB will act at the angiotensin receptor 1. So the clinical effect is still the same. Patient will have vasodilatation, will improve in the preload and the cardiac output, except that it does not cause cough. Okay. So the third drug is your beta blockers. So you have learned about beta blockers many times already. So it's a mainstay therapy in heart failure with reduced ejection fraction. Okay, basically you know beta blocker will block the beta receptors of the heart. So what will happen is that patient have negative chronotropic effect, negative inotropic effect. So the heart failure will reduce, the contractility will reduce. So is that good actually? Heart failure. You know heart failure is not pumping well, but now you are kind of blocking. Kan? So you think it's good or not? For patient with heart failure? Or will it worsen? It can worsen. Okay, it can worsen a patient with heart failure. But the main reason for giving a beta blocker is actually you want to block the sympathetic activity. Kan you know tadi compensatory mechanism kan, we have activation of sympathetic activity, activation of the renin angiotensin aldosterone system, but the main function of giving a beta blocker is not to actually improve the cardiac function, but you want to actually block the activation of sympathetic activity, because if the heart is not working and then you start to stimulate it too much, it's actually it cannot cope up, okay, with the stimulation. So you cannot actually give beta blocker in acute heart failure. Okay, patient datang to you with shortness of breath, patient is gasping, the blood pressure is quite reduced. Beta blocker at that point is contraindicated. Okay, you give a beta blocker once the patient is stabilized. Patient memang ada heart failure, memang heart dia memang dah enlarged, tak kuat, but patient is stable. Okay, they are not gasping, they are not shortness of breath, but you want to block the sympathetic activity, you want to maintain that patient in that way, then you can give a beta blocker. Faham? Not in acute heart failure, but in chronic heart failure. Okay? So, the criteria of using a beta blocker in heart failure, patient should be hemodynamically stable. The blood pressure is stable, and not in acute heart failure, no contraindication to beta blockers. Okay, patient is not in cardiogenic shock. The heart rate remains normal lah, near normal. The patient is not in bradycardia. There's no heart block, not asthmatic. But if you want to start the beta blocker, you start with the low dose possible, and then you can taper up lah. Okay, and you need to have a close monitoring of worsening heart failure or hypertension or bradycardia. So this is, although beta blocker is commonly used, but it's not so safe in patient with heart failure because patient can go into acute heart failure. Okay, instead you want to help him, patient can actually have a very severe adverse effect. But it's actually a good drug in terms of blocking the sympathetic activity. Okay. So you know the effect of beta blocker, will reduce the heart rate, reduce the contractility, patient can have bradycardia. If the patient has asthma, it can cause bronchospasm. It can increase the preload because it can reduce the contractility, but it can worsen the congestion. Okay, so you have to be very, very careful in using beta blockers. And there's also other adverse effect of beta blockers that we have repeatedly discussed. Okay. So the fourth drug is the angiotensin receptor neprilysin inhibitor, ARNI. So this is combination of two drugs, which is the ARB, Basatan, and another drug called Sacubitril. Okay, so Sacubitril is an inhibitor of neprilysin. So you give ARNI in patient with heart failure and reduce ejection fraction. Okay. And it works synergistically to reduce mortality and sudden death. So how does it work? You know how ARB works. It blocks the action of angiotensin 2 by blocking the receptor and result in vasodilatation. And sacubitril ni, they inhibit the enzyme neprilysin. Okay, it prevents the breakdown of natriuretic peptides. So natriuretic peptides ni, it causes vasodilatation. Macam angiotensin 2 tadi, it causes vasoconstriction. Okay, tapi natriuretic peptide, it causes vasodilatation, it will reduce the sympathetic activity, it will cause diuresis and natriuresis. So dia ada opposite effect compared to angiotensin 2. So now you have both drugs, the Basatan and the Sacubitril, producing the same effect. So that's why it's a synergistic effect. Okay, so I'm showing you. So when a compensatory mechanism in terms of reduce the cardiac output, there's two compensatory mechanisms. So you have the RAAS, renin angiotensin aldosterone system mechanism, and also the natriuretic peptide system. So natriuretic peptides actually causes vasodilatation, it reduce blood pressure, reduce the sympathetic tone, reduce the aldosterone level. Okay. So you give sacubitril, you inhibit this one, the enzyme here, neprilysin. So neprilysin convert natriuretic peptides into inactive metabolite. So when you block here, natriuretic peptides are actually working very well. Okay, and you block the action of angiotensin at the receptor, it causes this effect, the vasodilatation effect. Okay, so you have two drugs producing producing the same effects. So it's very good drug. But the adverse effect of that is that it can cause renal dysfunction, again because of the reduce in the renal perfusion. It causes hypotension, the blood pressure is reducing. It causes hyperkalemia because you are blocking the aldosterone effect. And there's also angioedema. Okay, it's typo there. It causes angioedema, but this is very rare. Okay, angioedema is usually due to hypersensitivity reaction. Okay, but it's a very good drug in terms of that. It has two different drugs, produces one or the outcome that we want. Okay, so the next drug is called the cardiac glycoside. or digitalis, and the example of drug is digoxin. So digoxin can be given orally or IV. It has a bioavailability of up to 75%. The half-life is about to 40 hours and excreted by renal and liver. So it is used in heart failure with reduced ejection fraction again. It can be used in atrial fibrillation. So you have learned about this kan? Drug used in antiarrhythmia or SVT lah. So the effect is that it increases the cardiac contractility. So how does it increase cardiac contractility? Digoxin here acts at the myocytes. Okay, it inhibits the sodium potassium ATPase. So when you inhibit the sodium potassium in ATPase, you inhibit the exchange between sodium and potassium. So potassium, there's no influx of potassium, there's no efflux of sodium. So sodium remains very high inside the cardiac myocytes. Okay, when the sodium is high, it will reduce the driving force between the sodium and the calcium. Okay, so there will less influx of sodium in exchange with calcium. So increase in sodium will result in increase in the calcium inside the myocyte, and this will increase the force of contraction of the heart, hence increasing the cardiac contractility. Okay, because of the calcium increase. Okay, at the same time, digoxin can also inhibit the AV node. Okay, when you inhibit the AV node, you are actually increasing the vagal outflow or parasympathetic activity, hence reducing the heart rate. So the effect is increasing in the cardiac contractility, but at the same time reduce in the heart rate. Okay, digoxin used to be the first line of drug in heart failure before, but it has been pushed downwards because of the availability of other drugs and because it has a narrow therapeutic index. Okay, so patient can go to toxicity very fast if you increase the dose a very small amount of dose. Adverse effects is dose related. In a low dose digoxin, it can cause nausea, vomiting, anorexia, color changes or blurry vision. A high dose of digoxin can cause malignant hyperkalemia and is very pro-arrhythmic. Okay, patient can go into ventricular tachyarrhythmia because of the hyperkalemia itself. So other adverse effect is rashes, headache, gynecomastia, and also weakness. So you cannot combine diuretics with digoxin because diuretics, particularly loop and thiazide, can cause hypokalemia. Okay, so bila it causes hypokalemia, potassium has less binding to that sodium potassium ATPase tadi. Okay, kat sini. If you have less potassium, less binding of potassium to the sodium potassium ATPase, and this will actually inflate the action of diuretics itself. Okay, so when you inflate the action of a digoxin, you inflate the action of digoxin, not diuretics. You inflate the action of a digoxin, patient will tend to have increase in the calcium more. Okay, so the heart has increased in the contractility, too much of contraction. Okay, so what are the indications of digoxin? If you cannot control the rate with beta blocker. Okay, maknanya kalau you give a beta blocker but the heart rate still remain quite high, you want to give or you want to add digoxin, kan, because it acts at the AV node tadi. Patient has contraindication to beta blocker. For example, patient has asthma or patient has diabetes. You cannot give beta blocker, so you can offer digoxin. And you need a rapid control of the heart rate with parenteral drugs. So digoxin can be given intravenously if the patient has tachycardia, but you do not want to impair the contractility, you can give digoxin. Okay, because it reduces heart rate quite fast. So contraindication is patient is hypersensitive to digoxin, patient has acute myocardial infarct, conduction abnormalities, myocarditis, hypokalemia, and renal impairment. Okay, ivabradine, I mentioned this before. Ivabradine, it acts at the IF current of the SA node. It controls the spontaneous depolarization in the SA node, hence it reduces the heart rate lah, by prolonging the diastolic depolarization. So I've shown you this graph before. I've shown you the mechanism of action of it. Okay, the clinical effect, again, it reduces in the heart rate in a use-dependent manner. Okay, so when they reduce in the heart rate, basically it improves the microcirculation and coronary flow. It helps with the angina of the patient. It helps with the cardiac output of the patient. Okay, adverse effect, patient can have bradycardia, atrial fibrillation, hypertension, and phosphine. Okay, so in the case of acute heart failure, patient comes to you again with hypoperfusion, increase in the congestion. So what you can do is, again, you go back to your basic ABCD, make sure the airway is patent, breathing, you give oxygen to improve oxygenation. So you give a high flow or 100% oxygen through high flow mask. Okay, you monitor the vital sign. So in acute phase, you want to reduce the symptoms of heart failure. You give IV diuretics to reduce the pulmonary congestion, to reduce the pulmonary edema, to reduce the peripheral edema. So the best choice of diuretics is which one? Thiazide ke low? Low. The best one is still low. Okay? Sebab it acts at the lobe of Henle, and that is the site of highest reabsorption of sodium and chloride, kan? So you want to block that side, kan? You want to make sure the patient has diuresis, natriuresis. You give a loop diuretics, okay, furosemide. So that is the best choice. Okay, and then you look at the blood pressure lah. If the systolic blood pressure is quite high, and you are quite safe to give a IV vasodilators, because it will bring down the blood pressure. It can reduce the afterload, it can reduce the preload. But what if the blood pressure is low? Okay, patient have hypoperfusion. You want to support with a sympathomimetic amines lah, kan? You want to give IV inotropes, dopamine or dobutamine or noradrenaline to increase the sympathetic activity. So we want to make sure that the blood pressure remains stable. Okay, so this is a balance, a check and balance lah between drugs. Okay, there's no standard rules of what you need to use, but you have to look at the condition of the patient, kan? You tak boleh bagi main hentam taram aja. Katakan BP very low, memang but patient is having congestion, BP is quite low, you bagi IV diuretics but you don't support the blood pressure of the patient, patient can actually go into cardiogenic shock. So if you give diuretics tapi you kena support lah with something else, kan? You cannot afford to give a lot of fluid. Patient already congestion, kan? So you give inotropes lah. So inotropes in form of sympathetic amines, which is dopamine or dobutamine or norad. Okay. Okay. This is just a summary of the drugs used in the treatment of heart failure. If you want to inhibit the activation of RAS, kan? You know that heart failure causes compensatory mechanism, and activation of the renin, angiotensin, aldosterone system. So you want to block that one, you can give either ACE inhibitors or ARB. Okay. So the choice of giving ACE or ARB depends on the adverse effect of the patient. If the patient is having very annoying cough, patient cannot tolerate that cough, you can resort to ARB. Okay, mind you, ARB, kenapa kita tak selalu bagi ARB? Kenapa kita bagi ACE first? Sebab ARB ni mahal sikit. Itu je. Okay, so you tend to give ACE first. The patient cannot tolerate, most of the time cannot tolerate lah sebenarnya. Jarang-jarang dengar orang tak ada cough because of ACE. Okay, unless it's very low dose, you can give ARB. But the effect of ACE inhibitors and ARB is apa? Long term effect dia apa? Which we are afraid of. Renal dysfunction. It can cause renal dysfunction. Okay, so you have to monitor the kidney function in patient receiving ACE and ARB. Okay, to prevent sympathetic stimulation of the heart, you can give beta blockers, provided that patient is not in acute heart failure, patient is stable, you make sure patient is not bradycardia and hypertensive. Then you can give a beta blocker. Okay, for heart failure, with reduced ejection fraction, you can give ARNI. Okay, angiotensin receptor nephroreducing inhibitor. So it is a combination of drug of sacubitril and valsartan. Okay, if you want to increase contractility of the heart, but at the same time you want to control the heart rate, you can give digoxin. Okay, digoxin acts as apa? Apa mekanisme dia? Sodium potassium ATPase. It will inhibit sodium potassium ATPase. In turn, it will increase the sodium and it will increase the calcium because it reduces the exchange lah between sodium and calcium. So that increase the contractility. Okay. It also reduces the increases the vagal stimulation of the AV node. Hence, you can reduce the heart rate. Okay. Additional drug to reduce the heart rate, you can give ivabradine. You know ivabradine, it acts at the IF current of the SA node. Okay. So I think that's all for now. So any question?